pleasant day to everyone. I am Madeline Gabriel Doromal, a medical social work advisor from the Health Facility Development Bureau. Today I'm going to talk about Administrative Order number 2021 or 0044, Guidelines on Determining Eligibility for Social Care, Medical, and Financial Assistance and Point of Service. My talk will be outlined as such. Health Facility Development Bureau, short background about our office, background and rationale of the administrative order, objectives, scope, and coverage, general guidelines, specific guidelines, frameworks for the eligibility, roles and responsibilities, monitoring, and assessment too. Start off, let me give you a brief description of our bureau, which developed this policy. The Health Facility Development Bureau, or the HFDb, is under the Department of Health, Policy and Infrastructure Development Team, or the hfdb-doh, which is led by Undersecretary Lilibet Dato. The HFDb, headed by Director Maria Teresa Vera, has an administrative unit and 3 functional divisions, namely Policy, Planning, and Program Development Division, Health Systems Development and Management Support Division, and Research and Performance Management Division. The mandates of the HFDb are as follows: develop plans, policies, programs, and strategies on health facility development, planning, operation, and management. Number 2, provide coordination, technical assistance, capacity building, consulting, and advisory services related to health facility development planning, operation, and management. And the 3rd, advise the Secretary and the Undersecretary of Health on the matters pertaining to health facility development planning, operation, and management. Let us now start with the talk on the administrative order. Let's move into the background and rationale. The waiver system or patient classification, as it is commonly used in health facilities, originated from RA 747, Series 1952, an act to regulate the fees to be charged against patients in government hospitals and charity clinics, classifying patients according to financial condition. However, this law is already superseded by a number of laws. One is RA number 8425, Social Reform and Poverty Alleviation Act of 1998, that defined the poor as those individuals and families whose income fall below the poverty threshold as defined by the National Economic and Development Authority and or cannot afford in a sustained manner to provide the minimum basic needs of food, health, education, housing, and other essential amenities of life. This definition is still followed by the Department of Social Welfare and Development today. Another policy is the 2014 RA number 10633, or the General Appropriations Act of for the year 2014, provided for the medical assistance for indigent patients, formerly Medical Healthcare Assistance Program, that identify their beneficiaries as indigent or poor, persons who cannot meet their basic needs or who have income but insufficient to fully meet their medical expenses, respectively, and are seeking medical services as inpatient, whether confined in the ward, intensive care unit, or small private room or outpatient in government hospitals. Another policy is RA 11291, Magna Carta for the Poor of 2019. The definition of the poor in RA number 8425 was reiterated in this law. For this administrative order, the mandate is now the MAIP, or the medical assistance for indigent patients, placed in the GAA of 2014. Aside from that, we also have the arrival of the RA 11223 Universal Health Act, which further provided policies that need to be considered in the eligibility. The law identified the financially incapable as beneficiaries of the point of service, mandated immediate access to health services, and zero out-of-pocket. This was followed by RA number 11463, the Malasakit Center Act, that mandated the provision of financial assistance to financially incapacitated. Okay? The objectives of Administrative Order 2021-0044 are the following. A. Ensure the financial risk protection of the financially incapable or incapacitated and poor patients in the progressive implementation of the Universal Health Act. This policy is intended to be implemented while we are transitioning towards full implementation of the universal health care. Letter B, streamline the processes and set realistic and objective guidelines for the assessment of financial capacity to access point of service. Malasakit Center's financial assistance waiver for treatment costs not covered by case rates, and the medical social work intervention for psychosocial concerns. Basically, this policy sets the guidelines for the eligibility of the beneficiaries of these services and programs. These guidelines are applicable to all hospitals, both government and private, PRCs, and other health facilities that require the assessment of patients' financial capacity or capability for social care, financial and medical assistance, and enrollment to costs. The private were also included because they were mandated to have basic ward by UAC. Likewise, PhilHealth have plans of including the private hospitals in the point of service. General guidelines, we go to the first general guidelines. Number one is all health facilities to the MSWD shall adopt this guideline in identifying eligibility beneficiaries for the following program. So we have already mentioned it. So enrollment of point of service. Number two, access to medical and financial assistance through the Malasakit Center. And three, prioritization for admission to basic ward accommodation, or ward accommodation refers to the provision of a regular meal, bed in a sheltered or a shared room with at least fan ventilation, and shared toilet and bath. This is defined by UHC IRR section 4.3. This is the former service or charity ward. Number four is waiver system on medical services not covered by case rate. And number five, social care refers to the provision of personal care supporting individuals with tasks of daily living and supporting people to engage with their communities. This is the MSWD interventions and services. Number six, other services deemed applicable. Letter B is this eligibility No balance bill could not be implemented. If all health facilities do not strive to ensure the availability of medicines, medical devices, including implants, diagnostic imaging, and laboratory tests to ensure that no other fees or expenses are charged to the patients classified as indigent or financially incapable or financially incapacitated as defined in this order. The out-of-pocket will increase if patients are made to purchase these items outside of the health facility. You, as medical social workers, can attest that these medicines and other supplies are really available because you are the ones who look elsewhere if they are not. Letter C. All health facilities shall maintain standard length of stay through the establishment of pre-admission planning system under the MSWD that shall ensure the following. When we talk of pre-admission planning under the MSWD, it is recommended to ensure that the standard length of stay is maintained or no illegal detention is done. The pre-admission services shall cover the following. Number 1, prompt identification of vulnerable patients. It refers to patients who are indigenous people, women, children, elderly, and socioeconomically disadvantaged, a population in crisis situation, uninsured, or those with certain medical conditions. Members of vulnerable population are often have health conditions that are exacerbated by unnecessarily inadequate health care, requiring contact, coordination, referral among doctors, nurses, admitting personnel, and medical social workers. The vulnerable at times do not know how to navigate the healthcare system. There are health facilities who require eligibility at time of discharge because they want to maximize the contribution of the patient. This is not the idea or the principle of universal healthcare, nor of people-centered perspective. Number 2, cost-effective and medically necessary care provided by healthcare team with appropriate referral done as needed. MSW shall closely coordinate with the medical team regarding their treatment plan and facilitate by making the appropriate referral. There are patients who have second thoughts about their admission because of financial or social issues, no? Like they don't know where to leave their minor kids, no? If they get admitted. Plan follow-up care after discharge during assessment. Patient's problem on discharge can be identified and addressed at the start of encounter to avoid delays of discharge. Okay. To follow in our general guidelines is the infirmaries may coordinate with local social worker office to perform the eligibility study. Since there are infirmaries and other health facilities that do not have a medical social worker, the facility shall coordinate with the social or the local social welfare office to perform the eligibility study. For the TRCs, the waiver system shall be in place since there is no approved base rate to the drug abuse treatment. We created this matrix to make the transition from AO51, AO31 to the new guidelines easier to follow. Okay? So, from AO31 to from AO51 to 31 to new classification used in Malasakit Center and classification under the POS. You will know what is the equivalent of the different classification provided in the AO51 and AO31 by comparing it in the matrix under the new classification. So this will hopefully help you adjust from AO51 and AO31 to the new classification for malasakit and POS. The old classification of D and C3 were now classified as indigent and malasakit, while financially incapable under the POS, financially incapable of POS included C1, C2 in the AO51 and partial payment under AO31. A and B under AO51 and full payment of AO31 are financially capacitated under malasakit and financially capable under the POS. Thus, the subclassification of A to D shall only be applied for uninsured cases. This will be discussed later. Malasakit Center Act provided the two terms of classification for its beneficiaries: indigent and financially incapacitated. The UHC Act and the POS provided the classification for each beneficiary: financially incapable. These mandates are the reason for the new terms or classification. Okay, let us now go to the specific guidelines of the administrative order. Starting with AO51, we have already implemented a more objective way of determining the indigent, poor, financially incapable, or financially incapacitated by computing the income ranges per classification. The criteria of determining eligibility will start with the monthly per capita income. What is a per capita poverty threshold? This refers to the minimum income required for a family or individual to satisfy essential nutritional requirements, such as 2,000 kilocalories and other basic needs as updated by the Philippine Statistical Authority. To determine the household monthly per capita income, the following steps shall be observed. 1. Determine the household monthly per capita income by getting the data about the income of all household members. The sum shall be divided by all household members, including those without income. Number 2, determine the 220%, 180%, and 140% cut-off value of the monthly per capita poverty threshold as updated by the Philippine Statistical Authority per region, where the concerned health facility is located, using the following equation: annual per capita poverty threshold divided by 12 to get the monthly per capita multiplied by the different percentage markup to determine the income range according to classification. Number 3, compare the household monthly per capita income with the cut-off values for the monthly per capita poverty threshold. The PCPT in NCR 2018 is 28,682 or 2,390 a month. In Tawi-Tawi, it is 21,264 a year or 1,772 a month. This disparity in the data is evident. This is the reason why we always want the facility to take the regional PCPT where the facility is located as a baseline. Computation shall be updated once the PSA publishes a new PCPT. Number 4. So, the income indicators for indigent, financially incapable, and incapacitated shall be supported by any of the following criteria. So, it's not only income alone that is our criteria for eligibility. This guideline included the level of social functioning that is assessed using the standard assessment tool. That includes the tools for adult, for children, and for elderly. Social functioning defines an individual's interaction with their environment and the ability to fulfill the role within such environment. So interactional, with the environment as work, social activities, and relationship with partners and family. In health, it helps the clinicians to understand the determinants and effects of illness. This is being done to prepare the medical social workers in the implementation of ICD-11. The income indicators for indigent, financially incapable, and incapacitated shall be supported by any of the following criteria. A. Patient having a severity index of moderate to catastrophic in level of social functioning and or economic basic needs system based on the person in environment framework, as referenced in the latest edition of the Manual for Medical Social Workers. Based on the 2020 statistical report of the medical social workers, 54% discharges were not covered by PhilHealth. The reason was that their PhilHealth was maxed out for the current admission. The admission was not covered by a case rate, or they were not enrolled for pause because of missing requirements of the enrollment. Based on this situation, the waiver system is still implementable. Waivers are a right to confer to an individual that entitles him or her to obtain health services in certain health facilities at no direct charge or at a reduced cost. This is what we locally term as classification. This provision is in line with PhilHealth Circular 2020-0024, governing policies on no co-payment, no balance billing for PhilHealth benefit packages. The said policies specify that NBB shall only be applied to members of the PhilHealth admitted in the basic ward accommodation. So additional criteria include the following modifiers arising from specific situation or circumstances. 1. The patient belongs to the vulnerable population as defined in this order. 2. Has personal circumstances such as crisis situation, disability, absence of social support system, orphans, elderly, solo parents, complex condition. 3. In community situation such as informal settlers, internally displaced persons due to natural or man-made disasters, armed conflict, or belonging to an economically disadvantaged or marginalized ethnic group. When treatment cost is more than their household income and is arising from chronic illness or disability. And 4, identified as complex patient, which refers to individuals who have multiple complex medical conditions or multiple detrimental social determinants of health, or a combination of both that contribute to the preventable service utilization and poorer healthcare management that ultimately negatively impacts the individual's overall health status. Okay. The 5th specific guidelines is the medical social worker shall evaluate patients as financially capable if the following are met. Number 1, a household monthly per capita income is higher than 20% of the PCPT income range of Class A and B. Number 2 is patients having a severity index of no problem to low in social functioning or economic base needs system based on the MSWD assessment tool that use the person in his environment framework as referenced in the latest edition of the Manual for Medical Social Workers. There are some operational changes included in this AO. So number one is the use of MSWD assessment form. As mentioned, there are 3 assessment forms: adult, children, and elderly. To determine the financial capacity of the psychosocial functioning of the patient and his or her family. Number 2, based on the psychosocial assessment framework, was structured to solicit and validate information in a therapeutic manner. Third is wellness, level of social functioning, problems in the environment, economic and basic needs of and affectional support system is determined. To understand the MSWD assessment tool and why it must be utilized, let us review the framework for the assessment tool. One is the ecological system approach, which is the perspective that believes the human problems are derived from the complex interplay of psychological, social, economic, political, and physical forces. When we say interplay, we refer to the two-way relationship, how individuals interact and respond to the environment around them, and how these interactions and affect society and the environment as a whole. Such a framework accords due recognition to the transactional relationship between environment conditions and the human condition. This is close to the person and environment concept with expanded macro intervention and the WHO social determinants of health. Person in environment framework perspective, on the other hand, in social work is a practice guiding principle that highlights the importance of understanding an individual behavior in light of the environmental context in which the person lives and acts. The assessment tool was adopted from the PI manual or James M. Carls and Karin E. Wondre. It has 4 parts: social role, problem identification, environment, problem identification, mental health, problem identification, and physical health, problem identification. However, the tool only covers the social functioning and environment. All social workers are trained at the assessment of patient situation with a psychosocial perspective. In health, we decided to use a more scientific way of assessment by using specific indicators in compliance with the ICD-10 system. Another framework for our assessment is equality and equity. Looking at the picture in your screen, what do you think is the difference between equality and equity? Equality simply means everyone is treated the same exact way, regardless of need or any other individual difference. Equity, on the other hand, means everyone is provided with what they need to succeed. During the pandemic, everyone received grocery as ayuda. Same box per family, no matter what the size, that is equality. There was a time that DSWD distributed financial help but only to the indigent families. So they conducted an assessment to determine those to be provided with financial assistance. That's what we call equity. Another framework that was adopted was the Republic Act number 10236, the Mental Health Act. The social workers were identified as mental health care provider. The medical social workers are expected to assess the psychosocial functioning of their clientele and provide appropriate intervention. Let us now go to the next operational change. Number 2 is all patients admitted in the basic ward shall be referred to the Malasakit Center using the certificate of eligibility, which shall be the official document required to avail of services in the Malasakit Center. Assessment tools can be attached or data shall be transcribed electronically in the unified intake sheet. This is referred to DOH-DSWD PCSO PHIC JAO number 2020-0001. Operational guidelines for the implementation of the medical and financial assistance to indigent and financially incapacitated patients pursuant to Republic Act 114060, also known as Malasakit Center Act of 2019. The need to do this is because of the no balance bill. Not all of the cost of patient's admission is covered by the case rate of PhilHealth. We are mandated to source out another party to cover the treatment costs and keep the cost of quantified free services down. This was the reason for Administrative Order Number 2018-001, streamlining access of medical assistance funds of the government. It provided for the process of streamlining PhilHealth, private insurance, mandatory discounts and benefits, PCSO MAIP, and the MOE of the hospital. This was suggested by the Malasakit Center. They made the mandatory discount ahead of the PhilHealth. Number 3. Assessment shall be conducted within 72 hours upon admission, except during pandemics or disasters. Elective cases may be assessed before the admission as part of the pre-admission planning process. So the 72 hours were adopted from the guidelines of the POS. Elective cases are those that urgent cases that can be scheduled. Number 4. Classification is applicable for 6 months to 1 year. Okay, so I repeat, classification is applicable for 6 months to 1 year. This has been established as a standard for medical social workers in the 5th edition of the manual. However, a lot of medical social workers are still unaware of this standard, creating miscommunication among medical social workers in one of the meetings in the Malasakit Center. Another specific guideline is the application of the assessment of the financial capability. So, when do we apply this classification? So, we apply it to the following. A, prioritization of admission to basic ward, enrollment to POS. C, motivate and direct contribution for PhilHealth. If the patient is financially capable, let us motivate them to pay their premiums. Letter C, letter D, counsel and mediate patients who refuse to be enrolled. Number 5, charge co-payment for services, professional fees, and amenities based on the co-payment guidelines issued by PhilHealth, regardless of membership type to patients who opt to avail of or to be transferred to non-basic accommodation. Letter F, assign a medical social worker in the ward, specifically centers that shall serve as case manager to complex patients. Letter G, fees not covered by PhilHealth shall be covered by the waiver system. So to continue, letter H, report the indirect contributors assessed by financially capable as part of the feedback to PhilHealth and the SWD. And then financial counseling, provide financial counseling. J, emergency patients as defined by RA 1093-2 or the Anti-Hospital Deposit Law shall utilize existing mechanism for medical and financial assistance to cover for all those services subject to existing guidelines. Number 6, operational changes. The UHC shall provide for primary care network. In order for the network and the facility to be sustainable, we should advocate for the proper utilization of our health facilities. Normal deliveries can be done in birthing homes, not in tertiary or level 3 hospitals, not unless they have complications. Other primary cases include essential hypertension, cholesterol, diabetes type 2. Let us now go to the roles and responsibilities of the different agencies involved in this administrative order. One is PhilHealth Insurance Corporation. They should review current mechanism process to validate membership to streamline requirements. No? In Annex D, you will see the number of requirements of PhilHealth. And number 2, adopt these guidelines in the process of enrolling patients in the POS. Letter B, we have the field implementation and coordination teams, where most of you are under. Okay, one is that they shall advocate for the implementation of this order with the health facilities under their respective cluster areas and ensure monitoring of the policy implementation. Letter C is our bureau, Health Facility Development Bureau. So our responsibility is to develop a monitoring system to be implemented through the Centers for Health Development. Number 2, develop a standard template for reporting the implementation of this policy. And number 3, provide technical assistance in the interpretation of this policy and the utilization of the standard psychosocial assessment tool. Number 4, release an annual report on the compliance of these guidelines. Evaluate the impact of the policy after 3 years of implementation. Malasakit Program Office. Adopt this order for assessing financially capable or capability of patients in its guidelines. Number 2, participate in the development of monitoring system. Letter E, Centers for Health Development, yung mga regions po natin. 1, ensure the compliance in the implementation of the policy through information, dissemination activities, and technical assistance by the respective health facility development units. Number 2 is to capacitate the medical social workers in the health facilities in implementing the policy in coordination with hfdb, certified resource speakers, and monitor the implementation of the policy in all health facilities in the region and submit a report to the HFDB using a standard click template. Letter F, Ministry of Health, Bangsamoro, Autonomous Region of Muslim Mindanao. Number 1, they will ensure the implementation of the policy through information dissemination, activities, and technical assistance by its health facility development unit. Number 2, capacitate the medical social workers in the health facility in implementing the policy in coordination with HFDB's certified resource speakers. And number 3, monitor the implementation of the policy in all health facilities in the region and submit a report to the Health Facility Development Bureau using a standard template. Letter G, kayo po, health facilities. Require the Medical Social Work Department, MSWD, to formulate an institutional policy that reflects both PCPP of the region where the health facility is located and the unique needs of the health facility. When making an institutional policy, we do not negate what is written in this AO, but we make it doable in your health facility. Number 2, ensure the conduct of the following through the MSWD. Assessment to identify financially incapable using the guidelines herein. Letter B, enrollment of non-PhilHealth members assessed as financially incapable and incapacitated are enrolled on the course, while the financial capable are motivated to pay in the PhilHealth premium. And letter C, provide the necessary psychosocial support or intervention to patients based on your evaluation. Number 3, to continue with the health facilities, the health facilities shall submit standard monthly reports of classified patients, annual statistical report, narrative reports, and psychosocial profile of patients to the HFDB as prescribed by the Manual for Medical Social Workers and reports mandated by MPO. We have 2 links for the statistical report for DOH hospitals, one for the services and one for the caseload. We will also be making a link for the LGU and private hospitals. Number 4 is to require the Hospital Finance Service to monitor quantified free services arising from the implementation of policy. Usually, the medical social worker is the one monitoring the quantified free services because management want immediate data. However, the true figure can be determined by the finance service post-audit, and they can really minus the markup. Okay, let's move on to the local government units. Monitor implementation among the health facilities under its management. And number 2 is adopt this policy in enrolling the uninsured to the cost for the healthcare provider network. In identifying the financially incapable, the ACPN shall either utilize the DSWD listahan assessment of medical social workers in the health facilities and the assessment of the local social worker, which facilitates when facilities are not facilities do not have medical social workers. An assessment can be applied and shared within the HCPN for 1 year. The assessment can be done either 1 year or if there is a cost for validation. We are now in the last part of the EO, which is the monitoring and evaluation. So, HFDB in coordination with MPO, FICTI, and CHG shall develop a monitoring system to determine compliance with the policy. The system shall include monitoring the cost of implementation, which shall serve as one of the tasks or the basis for PhilHealth review of case rates, and DOH and LGU reviews of budget allocation for their health facilities. An annual report shall be consolidated to determine the improvement of accessibility of the poor and vulnerable population and identify the social determinants of health used as modifiers, profile of the financially incapacitated, and the cost of assistance provided. Okay, if you have more concerns questions about this administrative order, please contact us with the information at your screen. Maraming salamat po sa inyong partisipasyon sa orientation na ito. Have a pleasant day.